So this is just one short part of Dr. Malek laid out misapplications of how microecon applies to the US healthcare system. And just to, start out, I wanted us to think about like some basic review on microeconomics in general. Now, I think this is basically the law of supply and demand is a theory that explains the interaction right between sellers of a resource and buyers of that same resource. And this theory will define relationships between the price of a good and product and the willingness of people to either buy or sell it. Generally speaking, as price increases, people are willing to supply more and demand less, and vice versa when the price falls. The key takeaways, though, are like the law of demand will state that at higher prices, buyers will demand less of an economic good. And the law of supply will state that at higher prices, sellers will supply more of an economic good. But really, these two laws interact to determine the actual market prices and volume of goods that are traded on a market. And of course, there are several independent factors that come into shape and influence this as well. In many industries, we think back to agriculture is always a good throwback. Demand drives supply often, but it can, like we just said, interact differently depending on the situation. If we take, for example, sugarcane, maybe not as much of a necessary agricultural resource as some other things, like some other staples, I think we can start to see how people can at least more easily decipher in such an industry what they need and what they don't. And they won't necessarily feel scared for their lives if they forego something. But obviously, this doesn't apply to healthcare. So I want us to really think about, in terms of healthcare, how demand is a market phenomenon. It starts with perceived need, right? And price, which is often a relationship to your household income and the insurance coverage you have, versus need is determined more so by so-called experts. And so in healthcare, producers or our clinical providers will induce this demand for their own service. Example is that please schedule a follow-up visit with me in 3 weeks. And of course, the patient thinks that's needed, so they're going to do it. There's very much that fiduciary relationship of trust there, right? Rather than have a decision made exclusively by that consumer. But I remember even in undergrad medical sociology class that I took, I was blown away that medicine is just such an industry that can truly get away with creating its own market always. There's always something else that you can medicalize. Some would argue that ADHD has become more and more medicalized, leading to overtreatment. Although, of course, the flip side of that is maybe it's just being diagnosed better, better awareness, or the incidence is increasing because of environmental exposures in today's society. But there's also things around pain syndromes that often maybe become minimized for some populations, but simultaneously can be unnecessarily medicalized. I know one thing that I thought about back then was restless leg syndrome and how all these ads were popping up, pharmaceutical companies pushing drugs to relieve this in the early odds. But some would even argue that diseases of old age can be over medicalized. So people feel the need to have to purchase that healthcare to treat those ailments. Osteoarthritis is one that we discussed earlier this year in medical school, and how that came to medicalized. Politically, I want you to think about how conservatives, though, are more skeptical of these so-called experts and even physicians in that sense. And they often tend to, when you're thinking about Dr. Keller's discussion earlier this week, value differentials that people sort of trend to common sense, or they emphasize maybe education as an approach to complying with recommendations. Now, on the one hand, you can't fully blame people, right? Because there is a lot of understandable mistrust in the world, but also I feel the pendulum has swung too far the other direction. And these days, there's so much mistrust of experts and lack of critical engagement. And this would be a lot less of a problem, perhaps, if we could reinstill trust in experts and have a more streamlined system like the kind we're advocating for, that's not bogged down by extraneous information and admin costs, and focused on actually meeting true demand for necessary services without creating unnecessary need for bottom lines. I want us now to really consider what Dr. Malek is alluding to around what perfect competition assumptions entail.
Hey, Shivani,
yeah?
can you hear me?
Yes.
In part due to all the background noise, I think you should probably speak more slowly.
Okay. Can you guys still hear me okay?
You're still competing with a lot of background noise there.
Okay. I'm sorry about that, you guys. I can definitely try to move to another location, but tell me what you think. Is this okay volume and speed wise?
Volume's fine.
Okay, cool. So one, perfect market assumption is that we have a homogeneous product, right? In such a situation, buyers have no reason to prefer the product of one seller to another. And this condition is present only when a commodity is a substance of a definite character, like a physical composition can be defined, say salt or wheat. Obviously, this does not apply something as amorphous as healthcare. And one doctor may tell, anatomic female that she has to get a hysterectomy done to cure for her painful fibroids, whereas another might be saying, oh, actually embolization or ablation would be better and less invasive for you. It can hold on to your uterus. Or someone else might say, oh, actually we should hold and do watchful waiting, and you can make some lifestyle modifications in your early 40s. And the reason I bring this example particularly is because a friend of mine in the Netherlands, ironically enough, who's from the US, and wishing she was in the States, but we had a discussion about that. She's struggling through that right now, and she's trying to have kids and really worried about this. But obviously, even when we heard from Dr. Malik's patient, Gordon, he was convinced that he had great care, right? So much so that he thought he had a really long appointment, and he would prefer to go to Dr. Malik. Obviously, healthcare is not just a single entity that's monolithic and every good is the same. I think we can agree for that, right? In the long run, under perfect competition as well, sellers and buyers, there's this notion that they can enter into or exit from the industry freely without any legal or social restrictions holding them back. Large number of sellers can be possible only if there's this true free entry of all market players. But I want you guys to think, do you really think people can freely just forego healthcare at some point unless they're okay to just not survive at the drop of a hat in their first illness? Like, what logic could we argue that assumption, right, in healthcare? So that's where I don't think the free entry and exit of producers and consumers really makes sense, but there's other arguments for that as well. Another thing to consider is that there should be this idea of perfect knowledge of the market on the part of all buyers and sellers. It implies that a large number of buyers and sellers in the market know how much the price of the commodity is in different parts of that market. In other words, there has to be this knowledge on part of each buyer and seller, the prices at which transactions are being carried, and the prices at which buyers and sellers are willing to buy or sell. But we violate this in healthcare, the medical field, all the time because a person does not really fully understand their disease or why their doctor is doing things, maybe thinking about the future course of their disease trajectory. And the decisions are really complicated, and the provider has the advantage of having completed a lot of extensive training. And even then, the provider doesn't have all the latest and greatest evidence-based knowledge, and things can go wrong. So how can they expect their patients to have this perfect knowledge if they can't? I think we can pretty much agree, that's just not happening in healthcare. There's so much opacity about what you're getting and what's going into the price. And also, like we discussed before, there can be beneficial perverse incentives why things change suddenly without the notification to those patients. It's just the mercy of the providers that they trust, that A, they'll know, and two, that they'll openly actually share this information. So another thing I want us to think about is how in a perfect market, there's this other notion of full mobility to move from any seller to another seller, or let's say provider to another provider, company to another company. Maybe we're talking about a prescription drug to another device or drug. There's no downside in an ideal market or cost of any sort to doing so. But even when there are costs baked in, the thing you should be moving to is of equally, like in every sense, equally great standard. But we know that this also doesn't hold true in healthcare because of how people are often stuck with the insurance providers they have in a particular network, or the one drug they can actually get coverage for. And so it's just not true that there's no switching costs in healthcare. Another thing is there are a large number of market producers and consumers in such a market. So
Shivani, I want to interrupt you just to go to emphasize why that's true.
Okay, go for it.
Like the theory says that Gordon White, that patient, should exit and enter markets freely. In other words, change doctors the very same way he would change brands of toilet paper. And yet, when we heard his situation, anyone taking care of him, like he spoke for around 40 minutes. And anyone taking care of him actually needs to know everything you heard, pretty much. There's nothing you heard that was extra. Like that's his social and economic circumstance. That's the context he lives in. And anybody trying to provide high quality primary care, and possibly even a specialist, really need to know all that. And they're not going to know it if he just goes to some other doctor and says, okay, here's my blood sugar. What do you think? He's in a complex situation. The familiarity that develops over time, particularly in primary care settings, is something you don't, it's not like changing brands of toilet paper. So I think that's a really good example of the one of the imperfections. There's not real motility. There's not a homogeneous product, and there you really don't want to exit a relationship with a doctor unless there's good reason, which there often is. The doctor's condescending or doesn't seem to care. So there are reasons, but it's just not the same as buying a different winter wheat from a different supplier. So yeah, yeah, go
Exactly.
ahead.
Exactly. And so another thing to think about is that in this ideal market, there's such a large number of producers and consumers on both sides, right? All the players. That means that no single buyer or seller can affect the price all that much. If a seller decides to enter the market or exit, there's going to be no real effect effectively on the supply. Similarly, if a buyer enters, is similarly just not going to be affected. And so maybe in a completely uninsured country, we could argue that there are lots and lots of buyers this way, in the way in which this theory means. And on the other hand, a lot of seller situation would be truly if like there were no insurance companies and all the clinical providers were simply competing with one another. Because truly, like you might think, well, wait, aren't the insurance companies also just like competing with one another? So aren't they considered the same? But no, they're not really competing with one another. And I think Dr. Malik's going to go into some of that as this internship goes on. The reality is that a lot of those prices balance out or set, or reach the same set point, and they also have sometimes different target markets and all end up winning at the end of the day. Just like how drug companies for biosimilar drugs can end up all charging the same at the end of the day because of how the patenting works, because of how the market ends up balancing out. So these mechanisms don't really allow for this kind of perfect competition to take hold, even though it means that in one sense, we're giving this kind of veneer of having competitive negotiation power. Another perfectly market assumption is that there's no discrimination or favoritism at play. Like buyers and sellers can just buy and sell freely among themselves without having any reason to go to a particular one. Implies that, everyone's willing to deal openly with one another to buy and sell at the same true market price. This might be true of one and all they wish to do so without offering like discounts or favors, but actually, and the reality is, as Dr. Malik just said, people are going to have their favorites. They're going to have the reasons why they choose a particular provider or they need a particular drug, and they will also have favorites in whom they partner with, providers that become in network versus out. So I think this is pretty obviously not like, it's very obvious that this just doesn't follow within the healthcare industry. And finally, I think even this goes without saying, under perfect competition, all the players have a common goal of getting the most bang for their buck and maximizing out their profits. There's really no like provision or concern for social welfare at the end of the day for the general masses. And healthcare, I think we all want to say that's not really our goal is, and it's not really feasible. And I know I mentioned earlier this week, and some of our speakers sort of touched upon it too, that this pandemic, at least in some ways, has shown us how all parties and socioeconomic groups are involved in our system, and we all sort of need to depend on each other for some aspects of our healthcare. We, whether altruistically motivated or not, have to kind of ensure to some degree the health of the welfare of the populace. So I think that's also something y'all would agree, right? Doesn't hold true. So overall, I think at this point, what everybody, and I want people to chime in with their points and or counterpoints or anything. Do you guys think like healthcare meets the assumptions that Dr. Koch was sort of making and alluding to too?
I want to answer your question, but do you mind? I think I missed it. Bullet 4. Do you just mind? Would you mind going over that one more time about? I don't remember, like what the term price takers mean.
So with price takers, I myself actually wasn't quite sure, and I wanted to let Dr. Malik touch upon this more. So I think I'll just let him speak to it.
Okay. So a price taker is someone who enters a market either in a perfect competition mode where the price of winter wheat is going to be determined by big supply, big demand. How much winter wheat really is there internationally, not even just in the United States? What the supply is like that year, and what the overall demand is from huge numbers of buyers of winter wheat. So if somebody enters that market to buy winter wheat, the percentage of the product that they're going to buy is tiny because this is a huge international market. So they're taking the price. They're not setting the price. Whatever the price is, they're going to pay it. They're a price taker. And in perfect competition, both the supplier, which is typically agricultural commodities like winter wheat, both the farmer producing the wheat and the person who buys the wheat are price takers. The market is so large that the price is set based on those big market factors, and that's perfect competition. The other situation where you're not a price taker is when you're facing a huge institution. So somebody walks into Mass General with a laceration on their wrist, they're not going to negotiate the price. Mass General is going to charge them something, in their emergency department to sew up their wound. And they're not going to say, well, I think I can get a better deal from another supplier, so they could take the subway, go over to Brigham and Women's and see if they can get a better price. Do you see? So they're price takers, the consumer, whereas Mass General is a price setter. They have power over setting their price. So it's got to do with power in the market. And I think Koch might have talked about that. Like, it's very important to him to be able to charge what he wants to. He's told me that when he's got my mouth open and I can't respond several times, that he should have power to set his prices. And that demonstrates his power in the market, because his patients can kind of take it or leave it in that sense. Does that help a little bit?
Yeah, no, that helps a lot. Thank you.
Yeah.
And so when you're saying producers and consumers, you're saying we as clinicians, the producers and the patient are taking these prices?
Now that most doctors are employed, I think the average doctor who's employed, who I work with, doesn't even have a clue what anything they're doing is going to be charged.
Right.
And it ends up even more complicated because the insurance companies may have contracts with where they're only going to pay a portion of what the institution is charging.
Okay.
So the price is not transparent, and that even the providers of care right in front of those patients don't even know. So it's different from Koch, who really is setting his price in his dental office.
Before we go on, does anybody else have some points they think could be cool to make or examples they can share?
I just had a question, I guess, for you, Shivani, is that when we were, I think it was Dr. Koch that we were talking to, he was making that food parallel or analogy, I guess, with choosing between organic food or shopping at your grocery store right down the way and the price. And I know a lot of people expressed that they didn't love that analogy, and I definitely agreed with all the points made, but I feel like there is some weight to the fact that analogy is good, but more in line with what we're arguing, because I don't know if all of the perfect competition assumptions apply to the food market either, because there's a lot of lobbying and stuff that goes into getting people to believe that certain foods are healthier, better for them. And there's a lot of ways that processed food becomes less expensive than food that's actually good for you. So I wonder if how you see that, and you think maybe that part of the analogy might have been actually good, but obviously a different point than he was making.
That's a great point, Jason. It's something I thought about too, because I felt like he really was trying. He was like, "Oh, I don't want anybody to end up with a peg leg or something." He does have good baseline standards, right? He was sort of just saying the fanciest prosthetic or eye, lens placement, maybe not. But overall, it was just such a crude analogy that was just cringeworthy. But I think you're right in that food industry, all industries really today, I don't think perfect competition assumptions apply at all. I think that's kind of one of the points. This is sort of classic agriculture, really looking, think of Sellers of Catan or something situation, which even then we know it doesn't work. So that's kind of funny in itself. Classic agricultural economies. I brought up the example of sugarcane because it's really relevant to Louisiana. And then wheat is the sort of staple we think of, right, in agriculture. But you're absolutely right. in today's food industry, that doesn't really hold true. And I think in that sense, it can be a good parallel. We can use that as like an arsenal tool.
Well, right. And I think he was saying, like, should they be able to get an organic potato when they could just get a regular potato? And I think more of the point is that they should be able to have access to fresh produce at all in the first place, not whether or not it's organic. I think that's the differentiation
Exactly.
that's important.
Exactly. And I want to just say that it's essentially what Mr. Cannon was saying yesterday, because I asked him, was like, well, what about access? And then I think I even maybe misapplied a term in my mind, but like, which he kind of harped on. But at the same time, he kept on saying, oh, quality, 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 which, I mean, okay, we're not talking about like the best potatoes. We're talking about any potatoes. We're talking about there's a famine, people are starving. So exactly. It's such a good point.
I think perfect competition applies to the wholesale market for commodities, like pork bellies and spring wheat, you know, those kinds of things. But at the retail level, it's much more complex. Like I'm lactose intolerant, but I kind of like milk. So I buy lactase. And I was in a store once and there was only the most expensive brand. And I found that the brands don't matter that much. So I read about this, and it turns out that big food companies that provides grocery stores with a lot of goods, they are paid to keep multiple brands off the market. They're paid to put the product in a place in the display that is favorable for certain products. So there's tremendous manipulation of markets by powerful suppliers, and a lot of manipulation of the market. So the whole retail market, has advertising going on to try to discriminate one product from another. So you're now getting away from perfect competition and into advertising and powerful producers that have money to advertise and can try to make their product special, like a Hostess Twinkie or something like that is more special than some random product. So trying to create discrimination and people willing to pay more for their brand.
And I think we can thank Edward Bernays, the father of modern advertising, for all of that, because that pretty much takes like perfect competition, blows out of the water. But I would argue actually that in even whole commodity sale, I don't really think this holds true from just knowing people in that industry and how they meet in Chicago. And like it's a throwback to like trading post days from Native Americans and stuff but even still is very good meetup point for those wholesale commodities. And there's a lot of reasons why certain things are bought at the prices they are. I don't personally think the perfect competition assumptions hold there fully. I'm trying to rack my brain of something that truly follows all the rules. I don't know.
Yeah, winter wheat is pretty good.
Maybe winter wheat.
I mean, some of the consumers, the agricultural co-ops can manipulate the price a little bit, but it's largely determined by supply and demand. And even the oil market, OPEC is a little weaker now, especially that the U.S.
True.
is producing so much oil, so it's closer to being perfect. However, within healthcare, perfect competition doesn't really apply anywhere. But so that's why these people who sort of argue that they think somehow competition is going to lower prices. Well, lots of luck with that. It's just there's so many reasons it can't. But starting with monopoly and market power within regional markets, and we'll get to that a lot next week in terms of regional hospital empires controlling local markets. And then in the book you're reading, The Hospital, there's a lot of that too. How these negotiations between insurers and hospitals go.
So I don't want to take up too much of our time, but I was going to say there was a study done by Rand in 1985 that Dr. Malek wanted me to at least allude to a bit, but she's going to maybe discuss too. And it assigned varying copay levels to randomly assigned population. So the pre-reading, I think you might have come across in a brief explanation of it, but this landmark health insurance experiment randomly assigned families to health insurance plans with varying levels of cost sharing. They range from nothing to 95% of that co-insurance. For poorer families and plans that involve the cost sharing, the amount of cost sharing was actually income adjusted to one of three levels. So it would have been 5%, 10%, or 15% of their income. Now, out-of-pocket spending was capped at these percentages or at $1,000 annual, whichever was lower. But what this study showed us is that cost sharing reduces healthcare costs by lowering utilization, but patients reduced, as we now take for granted as common sense, they reduce both their appropriate as well as inappropriate services, even proportionally. And the demand for healthcare was particularly reduced, of course, as we would assume, think about now, is take for granted, these low income and vulnerable populations. And so over the years, these findings have been confirmed in a lot of other studies. Nevertheless, the effects of these high deductible healthcare plans, which Dr. Malik's going to talk about today, on enrollee health and healthcare utilization is still controversial because they're often considered sort of blunt instruments. However, the use of these plans is seen by many policymakers as still a really powerful way to supposedly curb healthcare costs. It's considered extremely important idea in all of healthcare reform, even some very progressive reform measures. So, at the end of the day, I want us to think about, well, is this like something we would consider, like how will we argue back to especially with like progressive colleagues who are still in favor for some of these proposals, but maybe not everything. And really, like, I want to show this graph to show that when you have high deductible healthcare plans or even higher co-payments, this came out of that RAND study, a lot of essential services are lost. So I think we can all agree that immunization schedules for kids, early childhood sort of interventions, doctor visits are extremely important for cognitive development, proper development. When kids go without any kind of care, it's not okay. That's essential services. This isn't like an elective cosmetic procedure or somebody going to the doctor too much for something small. And as we can see here, it actually doubles in terms of the percentage of kids under 5 who go without care, no physician visits in a year, when copay increases just 25%. Now, if the copay goes all the way to 95%, this also rises another 8%. And it also kind of trends overall for a slightly larger age group of children. So we can see that. I think this sort of gets the take-home message. And this is not just seen for children's care, but a lot of other essential services. And some people argue, well, the RAND experiment was done in 1985, and there are studies that have like reanalyzed that data and done some smaller versions, but why don't we have any more randomized controlled trials? A lot of that has to do with, of course, be great for minimizing bias and unmeasured confounders, but at the time this could have been done because they could put people that wouldn't have gotten healthcare otherwise into a category where they can. And now that would just be too costly, and you would not want to take something that we know to be very valuable and important away for the study to work. So it's just not ethical or practical. Moving on from that, just want to show you, I think this will come across as also like something we take for granted. It's common sense, but the individual demand curve for physician services, this is what something they showed monumentally in their study holds true, that as the price of the services increases, the quantity will go down of what you actually utilize, and the whole curve shifts. And this is just showing when you have no out-of-pocket payments, what that essentially does effectively to the demand. And so this is also another study that was done a little bit more recently in 2015, reanalyzing that data, but also looking at employees that lost their supposedly great coverage, 150,000 employees. There was no evidence that these patients shifted to higher value care. And someone might look at this and be like, oh, well, there were less ER visits, like by 27%, which is maybe some of those were unnecessary, although we can't really say. And maybe some of the imaging, it's a good thing that went down. But also, like, what they'd be remiss to overlook is that preventative services went down by 11.5%, mental health, which we know is already underutilized and needed, and really important office visits, inpatient visits, and drugs that people probably depend on. So I think it's just really key that we don't overlook this, because some people will argue that, oh yeah, you only cut down on really unnecessary services. And some of those points we were making with Mr. Cannon yesterday is like, well, the only reason you have issues with quality or like overuse is because preventive services aren't utilized in the first place. They have no access to that, right? And what are other things I kind of wanted to touch on? I can just, I sort of wrap up at this point, unless I was going to say, don't be fooled by high deductible healthcare plans, which Dr. Malek will get into. But I wanted to sort of point out that the results of these studies hold up over time. And overall, I think we can agree that we should not be advocating for high deductible plans, maybe small copays like what Taiwan did to induce like medical adherence to things and have people have a little bit of like pride or buy into something. So those are really, really minimal. And now all of this is assuming like absolutely essential services. But then Dr. Malek and I talked a little bit about, well, what about things that aren't absolutely essential, but are also part of compassionate care? And he gave me a great example. I don't know if you want me to bring it up now.
Yeah, go ahead.
You sure? Of just like your friend who's a single mom and her son, I think he's a toddler, had accidentally zipped himself up the wrong way and ended up with scabs down there, his private areas, and his penis, and his mom was like freaking out. And a single mom didn't have knowledge, is also just an anxious person maybe, but rightfully concerned about how this could affect him or what happened. She didn't see it happen in real time. So she brings him to the ER, and if I understood correctly, like the person who saw them was like, oh, this wasn't actually a necessary visit. She was charged, I think, $400, $600 for the visit. And, that's a huge thing for her. And one could argue, well, maybe it wasn't absolutely necessary, but we're just being there for a single parent who's trying to do the best thing for their child. Like, isn't that compassionate care? And we talked a little bit about how elderly people, sometimes they just need someone at the end of their life. They don't have anyone and they're going to die. Is the care absolutely necessary? Someone just there to hold their hand, to talk them through things. That's just part of, I think, why we go into healthcare, to help people, to show compassion, to be healers. So this doesn't even take that into account. All of these studies, there's so much that you can't put a price on. And so it's funny because Michael Cannon was saying, oh, because healthcare is so complex, that's why we can't have a single payer system, because there's just nothing that can handle the behemoth of that. And the government is definitely not well suited to. But I would argue that it's actually because it's so complex in terms of human compassion and emotion. And we do need to care for these things. And a single payer system is the one that would allow us to do a better job of that. But I think I'll just end there and let Dr. Malek kind of go forward. This is meant to be a short presentation.
Thank you. Yeah, I guess my presentation will be short. Anyway, thanks so much, Shivani. I want to also say, so we're pretty much going to be done with what we have on cost control, except that I think Sheena is still willing to present the Democratic Party side of what's come out of the Democratic Party, in particular with Obamacare, for cost control. So today, and we've already I already presented, several slides talking about possible cost control strategies that single payer systems can use. With the top 4 in terms of potency being global budgeting for hospitals, which Adam presented yesterday. I thought that was a great talk. I really enjoyed that talk. And then my idea about software, creating standardized software that everyone would have, and that's a potent idea. Reduction of administrative costs built into a single payer system, and then ability to negotiate down drug prices. Those are the big 4. The other items on my multiple slides, 5 or 6 slides, they're all more on the order of a fraction of a percent. But again, my bias is that healthcare costs in the US are so hard to bring down that you take every little 0.3% that you can get, you take it. And so every single thing on that list. And after reading this book, The Hospital, I've actually added on consulting firms, because the healthcare market is so costly and overpriced that people, different market sectors get developed that are marginal. The only reason you need consulting firms is because of the complexity of the US healthcare, reimbursement structures. So that's actually an additional cost that we could get rid of, and that might be as much as 0.2 or 0.3% of overall US spending is wasted on consulting firms. So there's a lot there, and I think you have to, if one of you gets into a position of power when we finally have a single payer system, fight those battles. Save as much as you can, make the system as efficient as you possibly can. That's all I'll say. So today, I wanted to say a little bit, and I have 16 minutes. I want to say a little bit about the Republican Party and sort of organize what they have offered in terms of cost control. And I hope this is the right one. Yeah, so here we are. Now I'm talking about the mainstream version of the Republican Party. I'm just counting Trump and however his people may have modified all this, because I'm just using what we've traditionally gotten out of the Republican Party, which is pretty much what Dr. Koch, my dentist, was supporting. He's a much more traditional, what would be called a country club Republican, more relatively pro-free market. So they like high deductible plans, which I'm going to get into in a few minutes, and Shivani has spoken to pretty well. More competition among insurance companies, uh, which generally lead to less expensive plans with poor coverage. That's generally the model you get to when you're having multiple insurance companies. And again, I think the defect with multiple insurance companies, none of them are in a position to reduce drug costs or costs of inputs in general, hospital beds. They're with hundreds and hundreds of insurance companies, none of them have any market power. And so they end up being price takers when they're trying to buy a hospital bed or when they're trying to buy lisinopril. They're ending up being price takers. And have no market power to reduce prices the way a single payer would be able to. And then all the administrative costs of the doctors who have to deal with all these companies. Another one is eliminating state-based insurance regulation. So this is a big complaint in Vermont. Vermont has a more hefty regulatory apparatus, and that ultimately works to prevent patients from buying policies from other states. But if you can imagine, if Vermonters were buying policies from all over the country, if I were a provider and some patient had actually bought a policy from some insurance company based in Montana, as a provider, if I were like an independent practice and some patient wanted me to just bill their insurance company and it was based in Montana, I would just say, look, here's my fee. You pay me directly and you can deal with that insurance company. Maybe they don't even exist. Maybe they don't even have a fund balance, to pay anything. I don't know. And I don't have time to research it. So when there are, known insurance companies that I know within Vermont are in the state, and our state insurance commission sort of makes sure that they're viable and that they're going to be able to pay, the costs that their covered patients are going to generate, then I might talk about accepting that insurance. So, and furthermore, that insurance company from Montana has no power to get me to lower prices. So that insurance company from Montana, they have no market power. They have the only mechanism they can use to reduce their costs is to make the coverage worse. And have huge deductibles and allowing them their premiums to go down. Does that make sense to everyone? Or any questions about that concept? Because this is in Vermont, our Republican Party. This is always what they're coming up with. Oh, there's too much regulation. We need to go buy policies elsewhere. And it's like, it so won't work. Like what, why we keep going over this. Liability reform is the one area I do agree with them on, because this is based on my philosophy that any money entering the healthcare system should go to healthcare. And if it's diverted for any other cause, I don't like it. So this is my bias. Everything healthcare first. This is what I believe should be done, because I believe this struggle to reduce healthcare costs in the US is a difficult struggle. So and I was going to go over the big proposal coming generally from conservative circles. And this is to create a system with medical savings accounts. And either you could contribute just out of your own money, or as an employee, you could make a payroll deduction, have a payroll deduction from your pay. And some employers are willing to contribute to it, and they're deposited tax-free into a bank account. And that bank account is the employees. It's not at all controlled by their employer or by anyone else. It's the person's money, the employee's money. And it, let's say they're really healthy, and every year they're putting $500 into this medical savings account. They're putting it all in with pre-tax money. And later on, if they have a bad year of needing a lot of healthcare spending, they could then spend that money out of their medical savings account, and it will never have been taxed. So, and furthermore, during the period of time that it was sitting in that medical savings account, they were earning interest on it. So they had an account, they were healthy, and they're rewarded for being healthy and not spending that money by earning interest. And you guys, I don't know if you can even remember a time, you're also young, when the interest rates were not like 1%. They used to be higher, and that used to matter more, and it probably will in the future too. So interest does matter, holding money, who gets to hold money. So, and the idea is the money for people who remain healthy, the money later on could be withdrawn for other purposes. But in the meantime, they held it there drawing interest. And then if they take it out to spend on a vacation, it's going to be taxed at that point. But if they spent it on lisinopril, then it would never have been taxed. So this was the idea of creating bank accounts. And you can argue that in a sense, you become your own insurance company. It's like the biblical story of the 7, prosperous years of good agricultural production, followed by the 7 lean years. Like you put it away when you're doing well, and then you take it out when you're sicker. Can anybody think of the problem with that, as serving as your own insurance company?
How do you know how much to save? Like you could get in a car accident and be completely paralyzed, or maybe you just get the flu. Like you never know how much you needed to save.
Right. One idea is that it won't amount to enough money, which is generally true. But another idea is your sample size is not big enough.
I was gonna say you don't have anybody else to offset you.
Yeah, you need, to balance actuarial risk, you need 600,000 people. You're only going to have these policies for 30 or 40 years. What if you're sick every year? What if you have multiple sclerosis? You never build anything on. So who benefits from this are basically healthy people.
And question, are they capped at a certain amount of money, or you can put any amount of money? Because like a regular health savings account, like you can't just stack money in that thing.
Yeah, I think originally it was going to be up to $5,000 a year that you could get into it. And then, and it might have been a little lower. I'm pretty sure it's not allowed more than that. And part of the reason, in the next slide, these are the people who proposed this were proposing it in tandem with high deductible health plans. So in other words, these medical savings accounts were supposed to cover the deductible, and then the coverage that began at $5,000 was going to cover everything else. Okay, so you take a medical savings account that was going to, pay for the day-to-day care for your primary care doctor or something like that, and then the plan was going to kick in when you hit to $5,000. So that was the theory. And so who actually benefits from this? Well, people who are healthy. And also, this is tax deductible. And if you compare the wealthy and the people who are poor, who benefits from a tax deduction on their income tax? The wealthy do.
The wealthy.
Yeah, they may be in the highest tax bracket, which used to be high, before all the tax cuts of the last 40 years. But still, it's, it is in the 30% range. And if, that's tax deductible, that's, they'll take it. whereas somebody whose earnings are very low may be down in the 5 or 10% tax bracket. So those savings mean less to that person. So this whole idea is something that benefits people who are healthy and benefits people who are wealthy. And what you do is have the government subsidizing a private bank policy, a savings plan. And my model of healthcare insurance is that we all pay in when we're healthy, and all of the money is used for healthcare when whoever gets sick needs the care. And it's more of social solidarity rather than individuals peeling off their own plan to use for their own purposes and maybe to never use it. So it's just, to me, this is wasting money, allowing people who are healthy and wealthy to make money off of government subsidized, basically a tax deduction for, money sitting in their policies. So some of the issues with these, if you look at the provider side of this, and you're looking for the people to use what you could call judicious purchasing. So I'm arguing that it would affect primary care more than specialist care. And when I say judicious purchasing, I'm talking about a person with high blood pressure who's in my office, who's saying, I don't want to, the labs are really expensive. Can you give me a drug where I won't need to get a potassium level? But I might have had reasons to use lisinopril and hydrochlorothiazide, both of which need a potassium level. Like those are the biggest studies show that those are probably the first two drugs we should use, but they have that downside. They need a lab test. And so the person is trying to use judicious purchasing and try to get out of lab tests. Or I give them prescriptions for lisinopril and or hydrochlorothiazide and order the lab test, but they don't go. They're being judicious purchasers. They think, well, usually those drugs are okay, or he probably wouldn't have prescribed it, so I'll just not do it. And the other part of it is they could just avoid the service. So I've had patients say, well, I have diabetes and you're telling me it's bad enough so that I should have an A1C and come back in 3 months, but I'm making it 6. That way I'll spend less money and I'll do the best I can. I'll check my sugar, and try to do the right thing. And so I may be, and I'm already telling you that primary care is stressful and it's hard to keep up with my schedule, under the current circumstances. And Alicia Cunningham told you that too. And here we are spending time negotiating. And this is not what primary care should be using. Now compare this to neurosurgeon. So who's going to use a neurosurgeon? Somebody's up in there on a ladder getting junk out of their gutter, and they fall off the ladder and they have a subdural hematoma at 9 o'clock in the morning. By 2 p.m., and they're taken to the hospital, and by 2 p.m., they've blown through $5,000. There was never a negotiation. That neurosurgeon, totally unaffected by this kind of picking at cost, picking at preventive care provided in a primary care office. And you can well imagine that people whose money is sitting in that savings account, or just with high deductible plans without a medical savings account, which is what most people actually have with these high deductible plans. What about me? I don't have a medical savings account, and I didn't even realize how high my deductibles were until I actually spent the money and got the healthcare. So, but for people who are very price sensitive, a negative impact on preventive care and the care of people with chronic illnesses. And the slide on what happens to necessary care, Shivani already reviewed.
Dr. Malek?
Yeah.
So I was wondering if we talked a bit about this before in Shivani's presentation, that sort of providers can set the demand in a way that because they set appointments and such.
Yeah.
Is there any merit to the idea that providers are asking patients to come in too early, too often, and that's why these might be helpful. Is there any merit to that?
Probably a little bit, yeah. It might happen. I mean, I have to say that most providers I know are busy, and they, mostly don't like wasting their time because there's sicker people that, they have to attend to. So, I think the whole issue of trying to, what you would want to have happen is a really unnecessary procedure that's expensive, that people would negotiate out of that. And, occasionally that might happen. It's not, I work around mostly people who are competent, so I don't see a lot of specialists requesting unnecessary stuff. And I'm only calling when I have to, when something's really come up for a patient. Is there another question? But I mean, to the answer to your question, Shad, is yeah, I'm sure it occasionally happens. So the question is, for the healthy 70%, which I better have that graph. Here we go. Okay, so this is the graph that is the most important graph. I've already shown it to you. If I have anything to do with it, I'll show it to you multiple times again. These people on the right, these red bars in this graph, are the healthy, are the sick people who are using, 76% of healthcare costs. The healthy is 20%. Their costs are more than $5,000 a year, so they're not affected by the deductible. They're blowing through it. Now, there are some people who don't know they're going to be sick that year. They might fall down skiing and break some bones and spend a lot of money. So they might have been, conscientious consumers for part of the year until they had their injury. But really, a lot of people in this group, and the solid majority, they knew they were going to be sick all year. They're getting treated for cancer. They have multiple sclerosis. Something's going on. They have diabetes. They're blowing through those deductibles. So now you're talking about groups 1 through 7 on this graph. And their total spending is about 9% of overall healthcare costs. I think if you add it up, or maybe it's 10 or 11, you could add it up, those percentages, but they're small. So for those of you who are familiar with Willie Sutton, he was a bank robber, I think from the 1930s or 40s. And people asked him, well, why do you rob banks as opposed to other kinds of stores? He said, because that's where the money is. So who is high deductible, this judicious consuming? You're picking on the people who are not spending the money. And these people in groups 1 through 7 on this graph, you want them to go to the doctor. You don't want them to avoid medical care. You can discover they have high blood pressure. You can discover they're using drugs, and maybe they'll stop if you intervene. You can help these people. Maybe they have mental health problems that they'd be more happy and productive if they got them treated. So is this really where we want to skimp in our healthcare system? And furthermore, if we want to reduce costs, why not work on 9 and 10 and get the drug companies to stop charging so much for their multiple sclerosis drugs? Why don't you go after all the administrative costs that these sick people generate that are completely unnecessary? So I would argue that you're focusing your cost control in exactly the wrong place. It's not productive. You're not going to save very much because they're not generating much cost. This is why, even though we've had these high deductible plans for 25 years, since around mid-1990s, look at what healthcare costs in the US have what's happened. They've been completely ineffective. And yeah, the people spend a little less, but this is not a productive way to do things. I also object to diverting healthcare money. I already said this, and diverting healthcare money in the form of tax subsidies to healthy people, especially people who have a lot of money. I feel that healthcare money should take care of people who are sick and toward preventive care that keeps people well. So why did the banking sector lobby for this? This was not a random thing that this got passed. I mean, it may have been concocted by some right-wing economists, but the banks really like this idea because there's a charge to set up the bank account, and they hold the person's money and they're investing it. So they're making their little chink of money out of these medical savings accounts, which is more healthcare money being diverted. And so this policy diverts money to healthy, wealthy people and to the banks that are holding their policies. Poor use of healthcare money from my point of view. So, and then these policies add to administrative expense because everybody has to keep track of their spending so that when they actually get to the end of the deductible, where the company is going to cover them, they'll have, they'll start using the insurance, once they get to the $5,000. So you're not reducing any administrative costs. You're still keeping track of everything, and you're still dealing with, an insurance company eventually. And this policy you will predict that it would outcompete policies that have really good coverage. And that's borne out by the history, which is that higher deductible policies are increasing nationally. And for those of you who want to work out the economics, this is actually complicated math about how quickly high deductible plans in a market will tend to outcompete if all of the sick people avoid the high deductible plan in an actual competitive market. So what you'll see is high deductibles winning out and everybody ending up with crappier and crappier coverage. So these are my arguments against high deductible plans. And I think that's all I'm going to talk about for this.